Okay, everyone, we're going to get started. I am going to record the presentation as well so I could forward it along to anybody who missed it today. But thank you, everybody, for joining us today. We normally do these educational lectures in person. However, under the circumstances, we're hosting several virtual lectures so we can continue to educate the community and answer any questions that you may have. Our first lecture today that will be given by Dr. Meghan Bishop. Dr. Bishop's one of our sports medicine surgeons at Rothman Orthopedics. Dr. Bishop recently just participated in the U.S. Olympic marathon trials in Atlanta, Georgia. So we're extremely excited to have Dr. Bishop as part of our team at Rothman, since she can relate to so many of her patients who are active runners. So her topic today, she will be speaking on running during COVID-19. If you have any questions, you can put them in the chat section at the bottom, or you can ask them out loud after the at the end of the lecture, and we will get to them. All right. Without further ado, Dr. Bishop.
Awesome. Thanks, Jen. Thanks, everybody, for coming today. Again, my name is Meghan Bishop, and today I'm presenting on running during COVID-19. So teach you guys a little bit about some injuries that you might see during this time. So I know Jen kind of just gave a small introduction, but again, I'm a sports medicine and shoulder surgeon at Rothman, and I'm centered up in New York City area. So we have offices both in the city, and we have a couple up in Westchester as well. And like Jen said, I'm a pretty competitive runner myself. I just ran in the Olympic trials of the marathon at the end of February. And it was really lucky to get that race in, considering everything that happened immediately after. It was probably the last week that really people were traveling and things like that. So I'm pretty grateful that my marathon wasn't one of the spring marathons that were canceled for this. And it was an awesome experience. So a lot of you guys may have noticed, and if you're running yourself, that during this time period with coronavirus, there's really been a running an exercise boom. All the gyms are closed, workout classes are closed. So people are really just trying to get outside to be able to, first of all, get out of their apartment. But running is really the most easy and basic exercise to be able to get during these times. So there's a lot of people that are running more than usual, and there's also a lot of new runners that are starting. So this weekend, actually, I was rereading some of Born to Run, and I found a passage in it that I thought I'd include because I think it's really typical and similar to what we're going through right now. So just quick, and when things look the worst, we run the most. 3 times America's seen distance running skyrocket, and it's always been in the midst of a national crisis. The first boom came during the Great Depression. More than 200 runners set the trend by racing 40 miles a day across the country in the Great American Foot Race. Running them went dormant, only to catch fire again in the early 70s when we were struggling to recover from Vietnam, the Cold War, race riots, a criminal president, and the murders of 3 beloved leaders. And the third distance boom, 1 year after the September 11th attacks, trail running suddenly became the fastest growing outdoor sport in the country. Maybe it was coincidence, or maybe there's a trigger in the human psyche, a coded response that activates our first and greatest survival skill when we sense the raptors approaching. The equipment and desire come factory installed. All you have to do is let her rip and hang on for the ride. So this is the book Born to Run by Christopher McDougall, and I predict we might be going into another running boom right now. But on the contrary to this, the trails, especially around New York, if you haven't noticed, are incredibly crowded. So it definitely makes social distancing difficult in these situations. So some questions we're going to answer today. Is it safe to run outside? And if so, how? What kind of running injuries may you expect to see during this time? And how can we best treat them? So, in answering if it's safe to run outside, this study was just performed, a Belgian-Dutch study, looking at particle transmission during exercise. And they basically looked at, you can see these diagrams here, how far particles travel when patients are moving at faster speeds. So they found that people that are walking should stay at least 13 feet away based on the amount of distance the particles travel, which is certainly more than the 6 feet that most people, or the 1.5 meters that people are maintaining for when you're still. They found that faster runners, they recommended 30 feet distance. And they actually measured this at runners going 6:40 pace, so pretty fast time. And then cyclists who are really moving quickly need to be up to 65 feet away to really be out of the particle stream of other people. And when you look at these pictures too, you can see how the most vulnerable people are the ones that run directly behind. So most of the particles that patients or people give off are just directly behind them. If you run side by side, or if you run in a kind of catty corner position, you have less a chance of being in the slipstream of another person. Despite, the study coming up with these distances and looking at the amount these particles travel, there was really no comment on the amount of transmission with these particles. So, we can say that when you're outside exercising, these particles are going to travel further, and you may want to stay further than the recommended 6 feet apart in these situations. But there's really nothing based on the study that tells if there's actual high chance of transmission during this. A study out of China looked at transmission of COVID-19. And they looked at outbreaks in 4 different provinces in China, and they had 1,245 total cases. And they found most of these outbreaks were happening either inside the home or in transport, and they could be overlapping, and that's why these numbers are above 100%. But they found out of all these cases, only 1 outdoor outbreak occurred, and these were accounted for 2 out of the 1,200 cases that they had. So, they found all outbreaks of 3 or more cases were in an indoor environment. So despite the fact that these particles can travel further, the evidence out there shows that the chance of transmission in outdoor environments seems to be a lot less than when you're spending a consecutive period of time with people indoors. But given all this information, there are certain things that you want to keep in mind when you're exercising. So this was in a recent article published by Runner's World that was recommendations from an infectious disease specialist on how runners should handle spitting and other exercise activities outside during COVID-19. Most of these are pretty obvious recommendations. You shouldn't share water bottles. You should use good cough etiquette. If you're spitting, you should spit into a tissue, rather than around you in case of getting someone else in your stream. And then, if you're going to be to protect your eyes from stray droplets. And at this point, especially in the New York City area, experts are recommending wearing face masks at all times. So if you go on the trails around New York, it's very common to see most runners wearing a face mask. I think it's a good idea, especially to just be respectful to the people around you. If you're unable to stay the normal social distancing recommendation, which is pretty hard to do on the West Side Highway or in Central Park right now. So really what I've been doing is I have a cloth mask that I'll wear, and I only put it up when I'm near people or I can't appropriately socially distance, and then otherwise I just keep it down. And I think the cloth masks are easy to breathe than using like an N95, which would be incredibly difficult. And you can also wash them, which is a practical thing for runners. So going into kind of the benefits of running during this time, running is overall very good for you, and there's a lot of proven benefits of running for overall health. It improves cardiovascular fitness, can have reduced overall mortality rates, improved weight control, improved bone density and muscle coordination. Runners can have improved blood pressure, cholesterol extent, as well as lead to stress reduction, as well as reduce anxiety and depression, which during these times is certainly important as well. On the flip side, runners get injured. The annual injury rate of runners is around 50%, and the annual bone stress injury rates are around 20%. So the majority of these injuries, 80%, are going to be overuse injuries, and acute running injuries are less common. We usually see more bony injuries in younger runners and more musculotendinous injuries in older runners. So I'm going to go through kind of some common injury types and kind of how to self-diagnose. So first, knee pain is very common in runners. So a common complaint I'll get is my knee hurts. And when I think of knee pain in a runner, there's 2 main diagnoses that go through my mind first. So first is runner's knee or patellofemoral pain syndrome, and the second is IT band syndrome. So when distinguishing these, runner's knee, also known as patellofemoral pain syndrome, these patients are going to describe pain in the anterior or front aspect of their knee, around the knee cap. It's usually worse with bending in patients when they sit for a prolonged period of time. When you go up to standing again, that's when it's going to hurt. And particularly patients say this hurts when they're going downstairs, usually more so than upstairs, but it can hurt during both. On exam, sometimes you'll have some swelling, but most of the time there's no swelling associated with this. And you can sometimes feel some cracking underneath the kneecap, as well as see some lateral tracking or tracking of the outside to the kneecap. This has a lot to do with very tight lateral structures, especially seen in runners. I'm looking on the runners as a whole. They often have a lot of weakness in their quads or glutes, which can be contribute to this. And on X-rays, you can see certain findings such as a high-riding patella or sometimes lateral tracking of the patella or lateral tilt. And then IT band syndrome is the other and the patellofemoral pain syndrome, as these patients are going to describe lateral knee pain or pain on the outside of the knee, thigh or hip. So the IT band, you can see here, is this fascial structure that starts all the way up the iliac crest and comes all the way down and crosses on the outside of the knee and attaches to the tibia. So, most patients either get pain up at the hip area around the greater trochanter, or where that bone sticks out on your hip, or they can get it down where the IT band crosses the knee. These are most commonly seen in patients that have recent training changes. So I see a lot right now on patients that are picking up their intensity. And I often see it a lot of patients when they're tapering for races too, towards the end of their training cycle. Patients that have weak hip flexors and hip abductors are prone to this, and also patients that do a lot of running on uneven terrain or hills. So on exam, these patients are going to be tender along the IT band, most often just where it crosses over the knee or where it inserts on the tibia. And then they have this positive over test where you can be seen here, where essentially you're putting stretch on the IT band over here and eliciting pain. Basic treatment for these both these issues starts with rest, anti-inflammatories, and then so in physical therapy, we'll mostly be working on strengthening the quadriceps, particularly the medial quadriceps, as well as your glutes or your butt runners typically have very weak glutes, as well as core strengthening. I always recommend stretching, particularly for the IT band. Putting your knee into a figure 4 stretch can be very helpful for this, and you really can't overstretch the IT band, so you can stretch away. Foam rolling the IT band is awesome. Some people with the patellar tracking might want to try a brace around their kneecap. I usually leave this up to patients or taping or something like that to see if they think that helps them. But running with a brace sometimes can be kind of onerous. Additionally, I always look at patients' feet. So if you have a flat foot, you might want to use orthotics, making sure they have proper shoe wear, and then options for kind of recalcitrant cases. We can always try a cortisone injection for either of these, and sometimes the viscosupplementation injections can be very useful as well. And then, moving down the leg, another common complaint I get is my heel hurts. So when I think of heel pain, the two main things in runners I usually see are insertional Achilles tendonitis, as well as plantar fasciitis. So you can see the Achilles tendonitis, we're looking in the back of the heel, and the plantar fasciitis, we're kind of looking on the bottom medial side of the heel. So when we talk about insertional Achilles tendonitis, this is incredibly common in runners, and we see this a lot in a lot of professional runners. So these patients are describing pain at the posterior heel insertion, so right where that Achilles inserts onto the back of the heel. Usually it's worse in the morning when they first get up, so because the foot is put into plantar flexion all night long, and then when you step, you put your foot into dorsiflexion and can put stretch on that Achilles. And they describe often pain where the heel rubs against the back of the shoe. And you can sometimes get this kind of big bony spur that's seen on this picture here called a Haglund's deformity from that chronic rubbing of the heel on the back of the shoe. These patients are going to be tender to palpation where the Achilles tendon inserts onto the heel. You might see some thickening of the tendon there, as well as some swelling. You might see that bony spur I talked about, and it's going to usually cause pain with dorsiflexion. Achilles tendonitis is common with a sudden increase in training. Often get worse with activity with this. So if you go out and run, it doesn't really warm up very well. Like oftentimes during your run, it's just going to continue to hurt. And then if we get x-rays, oftentimes they're normal, but sometimes you can see some heel spurring or calcifications in the tendon. For plantar fasciitis, so to distinguish this from Achilles tendonitis, these patients have pain at the bottom of their foot near the heel. So that's signified by this insertion of the plantar fascia right here on the bottom of the heel. These patients usually find the pain is worse in the morning or after prolonged sitting. They're going to be tender over the medial calcaneal tubercle, and additionally have pain with dorsiflexion or flexion of the ankle. We often see this in patients that have tight Achilles tendon, high arches, and excessive training with minimal rest. Different than Achilles tendonitis, plantar fasciitis a bit more. And then, on x-ray, again, oftentimes these don't show anything on x-ray, but sometimes you can see a bone spur where the plantar fascia inserts, but this really hasn't, even patients that have these bone spurs, it doesn't necessarily correlate to symptoms. So for treating heel pain, Again, a lot of these treatments overlap for the two of them. Patients are always going to do physical therapy, and a lot of these based around eccentric protocols, or where we're trying to lengthen the tendon, things like calf raises, and really stretching out the elongation period of that. Heel lifts can really help. Putting in just a little heel insert, or like these gel cups here into the back of the shoe, can be helpful for a time period. And working on hip, again, and core and glute strengthening, everything's connected in runners. So keeping that as part of the physical therapy protocol is important. Particularly for plantar fasciitis, using a golf ball to massage the bottom of the foot can be useful. Obviously, ice anti-inflammatories. Here's a picture at the top right of a night splint, which some patients will use for both of these problems. That helps keep that foot into dorsiflexion at night rather than sitting in plantar flexion all night, and might help with some of those morning symptoms that patients have when they first walk in the morning. And then there's a couple more invasive treatments for more recalcitrant cases. So we can try something called extracorporeal shockwave therapy, which is essentially what's called lithotripsy, which is used to break up the calcifications in kidney stones. So people are using that sometimes on chronic tendon issues now to be able to help kind of create a new inflammatory response in there to stimulate healing. So that can be useful, and the benefit of that is oftentimes you can continue training when getting these treatments. However, they can be somewhat relatively uncomfortable. And we try to avoid cortisone injections into the Achilles tendon particularly, just because there have been chances of increasing rupture of the tendon, which can be a very serious thing if that happens. But a lot of patients will ask about platelet-rich plasma for these uses. Evidence largely at this point still does not support it. However, in certain cases, I do think it could be helpful. And then obviously for really recalcitrant cases, there are surgeries that can be done. You think of a lot of the really good runners, both Galen Rupp, who won the men's trials this year in the marathon, and the second place finisher, Jake Riley, both had previously had surgery for headwinds deformity on their heels. And then, our final complaint we'll finish with is my shin hurts. So when I think of shin pain, I think of either shin splints or medial tibial stress syndrome, or we talk about stress fractures, particularly of the tibia in this case. So for shin splints, these are more commonly seen in younger runners that have a sudden increase in activity. I see this a lot of times at the beginning of track season. And when I talk about shin splints, the pain is going to be along the tibia, usually the distal medial 2/3, and is worse with initial exertion and generally improves with exercise. When they get more significant, they will continue to hurt throughout. Important to note with this, the pain is more diffuse. It's on a larger scale at the attachment site on the medial aspect of the tibia. And oftentimes with shin splints too, this will be bilateral. A lot of times both shins will hurt. X-rays are typically normal, and if we get an MRI, we might see some edema on the outside of the bone where the lining of the bone is. When we talk about tibial stress fractures, these are important to distinguish because stress fracture obviously can become a significant thing if you continue to exercise on it. So these patients are going to have significant pain with weight bearing and often pain just at rest, even at night. And the important way to distinguish this between a shin splints is patients really have point tenderness to pain. So they can really pick the one spot on their shin that hurts the most, rather than more diffuse as in shin splints. Again, x-rays are usually normal. Occasionally you can see what we call the dreaded black line on the cortex of the tibia, but that's less often the case. These patients will generally send for an MRI. This will give the definitive diagnosis of the stress fracture. We might see edema in the bone or a possible small break. When we talk about treatment for these, usually this starts with rest and avoidance of aggravating activities, really till things quiet down. For shin splints, this can be anywhere from a couple weeks up to 6 weeks. Stress fractures, generally, depending on the location and depending on the severity of them, are going to be between 6 and 12 weeks of rest. During this time period, we look on strength or correcting any kind of risk factors that could lead to this. This could be any kind of nutritional deficiencies, such as vitamin D or calcium deficiencies. We will look at strengthening certain. Once patients are pain-free, they generally can slowly progress to unrestricted activity, especially for stress fracture. once we get to our at least 6-week time period, I generally say it needs to be about 1 week of no tender palpation whatsoever over that bony area prior to returning to running. These patients, their goal is going to be pain-free and completely non-tender prior to going back to activity. And when we go back, it has to be a very slow progression. So it usually takes about 6 weeks once you return to running to kind of get back to normal runs. But I usually go through a phased walk-jog program, which really starts with mostly, a 1-minute jog, then about a 3-minute walk, things like that, and we slowly progress on. So some take-home points today. Exercise and getting outside is important right now, not just really for physical activity, but for mental health as well. If you are going outside, make sure you're staying safe. If you should generally run alone unless you're with someone that you live with. And if possible, you should try to maintain social distancing guidelines or wear a mask if you can. For patients that are really trying to pick up running, you shouldn't increase your mileage or intensity too quickly. And I do recommend that you continue with trying to do some strengthening exercises at least 2 to 3 times a week. A lot of these injuries we talked about are fixed with PT, so you can really work on prevention if you can get ahead of it and do a lot of these exercises as your normal routine. And if you are injured, you should decrease your mileage, cross-train, or stop running, and then slowly return to your normal routine. So thank you very much, and I'm happy to answer any questions that you guys have.
Thanks, Dr. Bishop. We have one question in the chat section. Why would deep squats be harmful?
Deep squats?
Yes.
So deep squats aren't necessarily causing damage, and I think we're referring to like with patellofemoral pain syndrome. It's not necessarily causing any damage. I think that sometimes deep squats are just irritating to the issue for patients. So until they've gotten to a time point where inflammation's down and they've gotten that under control a little bit more, I think deep squats might just cause more irritation. Obviously teaching patients the proper way to squat. I usually have all my patients that I look at patellofemoral pain do a couple exercises in the office. I usually have them stand on a stool and slowly step down on one-legged just to see if they're able to control their knee. Most of them can't, and they're super wobbly. So then, that tells me that they're definitely very weak in their glutes and their medial quadriceps. I usually have them do a squat as well to simulate a squat to see their form. And most of these patients, do terrible form with their knees completely over their toes. So those are things that I think need to be improved with these patients. But really the reason why to hold off on deep squats is just because it's more irritating to those patients. They're fine to incorporate it in later once we've kind of corrected some of their deficiencies.
Okay, thank you. Does anybody else have any other questions?
Great. Well, thank you, everyone. There might actually be one more.
Yep. Nope. I actually just sent in our number, our scheduling phone number. As Dr. Bishop mentioned, she sees patients at our offices in Manhattan at our Gramercy location, and also in Harrison, New York. We normally see patients at our offices in Tarrytown and Mary Hill, but they're both temporarily closed. We're hoping to have them reopen very soon. We're currently seeing patients in the office, and we're also doing tele visits for those that are not comfortable with coming into the offices still. They just recently just lifted surgical restrictions in Westchester County, so we're hoping Manhattan will shortly follow. But if you would like to schedule an appointment with Dr. Bishop or have any questions for us at Rothman at all, I just sent the phone number in the chat section. I actually we just had another question. I've dealt with a lot of injury this year and have worked on form. How should I lay out my training when getting back into it?
Good question. I mean, I think that it sounds like you've started with a good way to start by working on form and working on some of deficiencies that you may have that could lead to multiple injuries. My advice would be to kind of start out slow and work on the basics. I had a pretty bad injury to my proximal hamstring last summer, and I was jogging up to only a mile for like a couple weeks back, just to make sure that you're not falling back into old habits, especially if you've been working on your form, just to really try to make sure that your body is ready to come back. So starting off slow, not increasing intensity or mileage too quickly, continuing to incorporate strength training, your PT exercises that you've been doing, being good about making sure that you're have the appropriate shoes to wear and not, overrunning your shoes. Continuing the stretching, sometimes massage, I think is really helpful, especially for older runners. Just, really making sure you continue to take care of the details.
Okay, great. Thank you. If anybody else has any additional questions, feel free to email me directly and I will get the answers to you. But if that's it, thanks again, everyone, for joining us today, and stay safe. We hope to see everybody soon. Have a great day.
Thanks, everybody.